So today I want to tell you about the importance of first heart sound. So cardiology, entire medicine lo first heart sound plays a very major role. So I thought of actually showing the video of how the valve closes and all, but lack of time. Just want to show you what is the importance of first heart sound. So anatomy and physiology, and next, what are the causes for loud first heart sound, causes for absent first heart sound, soft first heart sound, differential diagnosis of first heart sound. Anatomy of the first heart sound. First heart sound is made up of two valves, mitral valve and our tricuspid valve. Out of this, the 85% of the mitral sound is created or is because of the mitral valve. So tricuspid valve also plays a major role. Only thing is in second heart sound, there will be always a split of the second heart sound. But in first heart sound, you should never say split of the first heart sound. So most majority of the time it is a single first heart sound. So once it described in the exam, entire medicine is based on the first heart sound. Most difficult thing to make out in an exam in your life, in your practice is making out a first heart sound, because this is one part which we are not getting trained, and we are just passing and going and looking after ECG, echo, angiograms, but we don't know our chest X-ray. Sometimes we don't know how to make out a first heart sound, and nobody will come and tell you this is the first heart sound, this is the second heart sound. They won't, people won't come with a board, or they won't come with a graphic design where you can make out your first heart sound. So it takes minimum 3 to 8 months to make out, detect, auscultate and make out first heart sound. So first heart sound should be described as a single sound, well heard with the bell of the stethoscope in the left lateral position in a quiet room, well localized at the apex, with no major variation in respiration. So all the five characters you have to describe when you tell a first heart sound. It is a low frequency. How to make out high frequency means you use a diaphragm. For low frequency, you use a bell. So first thing I have to describe about first heart sound is it is a sound which is well localized and it doesn't have any radiation. So you can't say first heart sound radiating to the carotids, first heart sound radiating to the epigastric region, first heart sound radiating to the axil. Like that you should not tell. It is a localized sound. It is a localized sound, a well heard. I heard a first heart sound which is well heard in the left lateral position at the apex with the bell of the stethoscope, and no variation with the respiration. Second heart sound varies with the respiration, whereas first heart sound doesn't radiate with the change with the respiration. That is how you have to complete a when you're writing a case sheet or when you're telling the exams. Entire life is based on the first heart sound. Because we are missing the first heart sound, so many mistakes we are doing in the clinical examination later on in the career. So conditions, first of all, to make out first heart sound takes a long time, more than 3 or 4 months, because once you put a stethoscope, you'll be hearing a breath sounds, you'll be hearing tracheal sounds, you'll be seeing abnormal sounds, you'll be hearing murmurs, you'll be hearing lot of other things, even abdominal sound. So how to make out, is it abdominal sound, is it a respiratory sound, is it a heart sound? Nobody knows. And unless you know first heart sound, you don't know what is systole, what is diastole. So the importance of first heart sound is this is the only sound to make out whether it is you are hearing a systolic murmur or diastolic murmur. If at all you don't know what is first heart sound, how you can tell I heard a systolic murmur? Easily you are confusing yourself with the systolic murmur to diastolic murmur. Once you confuse with the systolic murmur to diastolic murmur, entire treatment will change. For diastolic murmurs that are there in the heart are most common is mid-diastolic murmur heard in the mitral stenosis. Second common heard is heard aortic regurgitation. Third is pulmonary regurgitation. These are the common cause of diastolic murmur. Out of that, 60 to 70% we talk about diastolic murmur means about mitral stenosis. But also we can hear in continuous murmur like patent ductus arteriosus. Whenever there is a huge difference between artery and vein, then also you hear a diastolic murmur. So any patient who was stable early now has developed a diastolic murmur means you have done an aortic implant, surgeon has gone away, night you are on the duty, and now first time you are hearing a diastolic murmur, there is a leak in the aortic valve. Clinical examination is very important. That patient is going for a left ventricular and diastolic pressure, and the patient is going to die. That much of importance is there for a first heart sound. So if at all none of the doctors out of 199% they don't know how to make out a first heart sound, but they know how to interpret ECG, they know how to interpret angiogram, they know how to interpret MRI, and one lab report comes potassium high, one lab report comes Vidal positive, one lab report comes jaundice positive. These are all the problems with the bedside. We are not teaching bedside clinics. You have to understand that bedside clinics, you have to dedicate again after completing your MBBS, 2 years at least you have to sit in general medicine ward. 36 subjects are there in medicine, so you cannot focus on each one subject. After that, in internship, unfortunately, they are rotating and rotating, rotating. Finally, brain is getting rotated and nothing is learned. So, MBBS doctors and MD physicians and DM cardiology, clinical bedside in India is zero. Last 20-30 years, our teaching is zero. So, what all that is there in all only flexes and designs are there. Pure knowledge in the brain is zero now, because you cannot, your people are not interested to come back at the medical college and relearn. You are always going for PG exams and other exams and specialty exams, and you are not having any time to put a step on the patient. So if you don't know apex, you don't know first heart sound. For example, you said first heart sound is well heard loud, and if I ask you the apex, you say apex is not seen, you are wrong. That itself you can make out that you are wrong, that you are copied in the exam. So apex is one first important clinical examination. Unfortunately, none of you are practicing at home. Nobody knows how to palpate the apex. None of the doctors in India know how to palpate the apex. That is the way we are learning medicine, only by hearting and going on. Unless you know the apex, then you localize to that area, then you auscultate. So causes for conditions where heart first heart sound can be palpable is mitral stenosis. So causes for loud first heart sound, causes for normal first heart sound, causes for absent or low, small or soft first heart sound. Basic mechanism of physiology of first heart sound is it depends on both mitral valve and tricuspid valve. The four factors which determine the loudness of the first heart sound are: one is mobility, M; T is thickness of the valve, MT; C is calcium; 4 is subvalvular apparatus. So MTCS. I will give everything online. So I am recording all this. I'll send a PowerPoint to you, and also I'll send a audio podcast and video podcast. So you need not read anything. Just you have to follow. So mitral valve always there is. What is the role of mitral valve? It prevents when the heart is contracting during systole, the blood should not enter the left atrium. What is the role of mitral valve? It allows the blood in the left atrium to fill the left ventricle. This is the where the mitral valve has a in between the connection between left atrium and left ventricle. And always congenital anomaly should be remembered when you think of mitral valve. So congenital mitral stenosis, cleft mitral valve, and abnormal congenital anomalies of mitral subvalvular apparatus, they all can cause abnormality in the mitral valve closure, which can bring difference in the loudness of the first heart sound. That is why embryology and anatomy and physiology are very, very important pillars. We have to keep anatomy physiology in the final year exam. So first year exam, the value we don't know. So the physiology of the heart is, it always depends upon the mobility of the mitral valve. If the mitral valve is able to open totally and the left ventricle is able to relax fully, then there will be widening of the mitral valve. So by the time they come together, then you will get a good sound. If the left ventricular and diastolic pressure is high, the mitral valve will not be able to open totally. It will be only opening two-thirds. Then it closes, the sound will come down. So yesterday you had a first ICU, very good first start sound. Doctor went away, chief went away, cardiologist went away. You are on the night duty. Suddenly the patient became breathless and the first start sound has come down. That indicates his left ventricular and diastolic pressure is gone. Whenever the left ventricular and diastolic pressure increases, the mitral valve will fail to open totally. So the mitral valve has to open totally and then close. Then only you will get a loud first heart sound. And if there is any electrical disturbance, the first heart sound will vary. In tachycardia, fast heart sound will be loud because there will be shortening of the cardiac cycle. Whenever there is shortening of the cardiac cycle, systolic part comes down. The heart has to contract at a very fast rate. The mitral has to close immediately, and the heart rate goes up. So in fevers, will be hearing a loud first heart sound. So causes for loud first heart sound are physiological and pathological. Physiological causes are first is anemia, second is fever. Third is thyroidosis or any conditions where there is a high cardiac output. So high cardiac output conditions. Four, anemia, fever, hypothyroidosis. These are the conditions, and rarely in malignancies we see. So out of that, you should know that the mobility of the mitral valve is normal. Once you are telling the law, I am able to hear first heart sound, you should not say mitral regurgitation because you yourself committing that your mitral valve is normal. First heart sound is well heard means your mitral valve is normal, mobility is normal. Next is thickening. Whenever the mitral valve is thickened, the first heart sound becomes soft. So causes for soft first heart sound is when the valve is completely destroyed. Second is when the valve is completely calcified. Third is when the valve is completely edema. Thickness is there. Next is subvalvular apparatus contains two parts, both muscle and tendon. So mitral valve prolapse is wherein you see a damage or sometimes myocardial infarction. There is a rupture of the subvalvular apparatus. Then also the sound will come down. So causes for soft first heart sound are complete destruction of the mitral valve, calcification of the mitral valve, thickening of the mitral valve. So a patient who had a fever yesterday, as a young girl, came with joint pains, fever, rash yesterday, and the patient had a tachycardia. Today, the patient first heart sound is gone. That means the valvulitis, rheumatic valvulitis. How to differentiate acute rheumatic fever from chronic rheumatic heart disease? Both are mitral diseases. Who will tell is it acute episode or is it already a patient with chronic rheumatic heart disease? Nobody will tell. Only way to make out is when mitral heart disease, rheumatic heart disease, first heart sound is loud. Once the patient has developed acute and chronic rheumatic heart disease, or a patient is coming with the first time of a rheumatic fever, is classical feature of acute rheumatic fever, valvulitis. Anywhere valvulitis means edema of the valve, the sound will come down. That is how you have to correlate. So on chronic rheumatic heart disease, acute rheumatic fever, and chronic rheumatic. So there are three patterns in simple rheumatic heart disease. So just you cannot say everything as rheumatic heart disease. So that is where first heart sound plays a major role. Causes for short first heart sound are abnormality in the thoracic cavity, that is the rib cage anomaly. If there is any change in the rib cage anomaly, you have developed, you are unable to auscultate the patient, the ribs will be causing obstruction. Second is if there is a fluid between the heart and the stethoscope. So pleural effusion, large pleural effusion, you can develop a artificially sound will be left. Third is pericardial effusion. Fourth is when there is a thickening in the pericardium. Then we come to the mitral valve. Valve, if it is completely destroyed, you will get a low first heart sound. So causes are low first heart sound are two: physiological, pathological. Physiological most common cause of soft or absent or difficult to hear first heart sound is COPD. Any emphysema if it is there, first that is where you have to palpate the apex. If you are missing the apex means that means if in a case of COPD, what will happen? You will get a tubular heart between the two lungs will compress the heart, and if the heart becomes tubular, and you will be feeling the apex at the xiphisternum, epigastric region. So once you commit that the on palpation, I am able to make out the apex in the epigastric region, and you say first heart sound is loud means you are wrong. You understood? You must commit your apex. So unfortunately, 99% of the doctors in India, they don't palpate the apex. But they go to ICU, they manage it, they do angiogram, they do a stent, and MRI, CT scan. For a simple pneumonia case, they are doing a CT chest. But nobody is going to see at the apex. So any case with emphysema, if it is there, you have to see the apex first. But they are seeing at the chest X-ray, and then they get confused. Understood? So first heart sound, softening of causes of first heart sound are ribcage anomaly. So physiological, pathological. Physiological are ribcage anomaly. Second is lung tissue in between the heart and skeletal system. Third is fluid collection. Anywhere if it is there is a fluid collection. Pleural effusion. Next is pericardial effusion. Next is constrictive pericarditis. Next are differential diagnosis. Any other sound which mimics a first heart sound. What are the events are opening snap, tumor plot, first heart sound. Rarely split of the first heart sound is seen in bundle branch block. So who will tell is it opening snap, is it first heart sound, is it tumor block? Nobody will tell. Only way to make out a first heart sound is you have to put a thumb on the carotid and you have to palpate the apex and you must localize the apex first of all, then put a step there. If it is correlating with the carotid pulse, then only it is first heart sound. Once you make out and it should be felt at the base of the heart, at the apex of the heart, only you should feel the first heart sound. You should not say first heart sound heard at the second aortic area, pulmonary area. Only if it is able to auscultate at the apex and you correlate with the carotid, it will take minimum 2 to 3 months for the finger movement to correlate with your auscultation. Immediately, as soon as today you put a stethoscope, tomorrow you will not hear a first heart sound. And you must start with the children and then slowly come up. By the time in India, most important common cause for soft first heart sound is obesity. So in women with a large breast, you will be missing first heart sound, and obesity is very common in India. We are missing the first heart sound. Any change in the diaphragm, push of the down of the diaphragm, or if there is any change in the diaphragmatic congenital anomalies, then you will be having a change. So first of all, you have to palpate the patient. Can you make out a liver in the right side or not? So is there any dextrocardia or not? That we have to confirm. If there is a case of dextrocardia we are given, 99% of the doctors are missing. Why? Because they are writing first heart sound heard in the left to fifth intercostal space where the apex is in the dextrocardia. We can make out that you are not even seeing the patient. Nobody is seeing the patient. After CT scan, they are coming back and seeing that the patient has dextrocardia. So is with the situs inversus or without situs inversus? Isolated dextrocardia is very common. So livocardia patient, I'm able to hear a first heart sound because I palpated the apex at well localized. It is a low frequency sound, heard best with the bell of the stethoscope in a quiet room and no much variation with the respiration. That is how you have to finish a first heart sound. Then only you are correct. It is a normal first heart sound. Understood? If you don't practice like this, lifelong you will be confused. It is systolic member, somebody will say diastolic member, somebody will say systolic member. So nobody will know whether it is a systolic member or diastolic member. Entire treatment will change. So I told the anatomy of first heart sound, I told the physiology of first heart sound, I told the etiopathogenesis of first heart sound. Next is I told you the causes of what is the mobility, thickness, calcium, subvalvular apparatus. Contribution of the first heart sound, mitral valve and tricuspid valve. Next are causes for loud first heart sound, causes for soft first heart sound. Physiological causes, pathological causes. So if you miss the physiological causes, unnecessarily case of anemia, there are so many patients, crores of patients with anemia treated as mitral stenosis or treated as a congenital heart disease or treated as coronary artery disease because the first heart sound was low. Thyrotoxicosis patients are missed because nobody is seeing the endocrinologist, they won't go, they come directly to you. And as most important is in hypothyroidism, Hashimoto's, you will hear a soft first heart sound. There will be always bradycardia. Also, there will be some amount of pericardial effusion, very common. In the end, these patients chance of getting a